happy to meet this very important meeting, and I hope to give you useful information for have a correct use of a revolutionary protocol that we use for artificial hair implantation. This is the issue of this presentation. The next, please. Next, Graziana, can you go ahead, please? Move the next. Okay, thank you. I want to summarize my history. I am a former professor of surgery at the University of Modena Medical School. And since the 1970s, the company Medicap approached our research group in order to find out a possible fiber to achieve production and marketing of artificial hair implantation. We started this study examining different surgical future, especially in ophthalmology and cosmetic surgery, in order to find out the best biocompatible fiber. And the company was very much satisfied when polyamide was proposed by our group. And so they went on with the certification of the product with CE MDR certification, and also TGA Australia for a sure quality and safety of the product. Next, please. The next. La prossima. So let us give a look to a comparison between the two main competitors in hair refreshing. The first one is autologous bulb transplantation, that is biological procedure, and compared with our biofiber, which is quite different because the autologous implant requires healthy donor site, usually occipital site, and a scar because we have to take out a short line of tissue. And in our case, biofiber, artificial, does not require any donor area. And so it can be used also in completely bare depleted donors. And the result requires 9-12 months, the time of recycling of hair growth in the autologous implant. And in our case, we have an immediate, extraordinary aesthetic result. The duration of the implant autologous is semi-permanent. In our artificial implant, we need periodical refreshing in order to maintain the density of the fibers into the scalp. The safety, finally, is good standard for autologous and very good also for us because we can take out the fibers without any scar. Synthesizing modern artificial implants are not replacement for biological restoration. They are the necessary complementary alternative for severe alopecia, depleted donor areas, and scar burns correction. Next, please. Now, we give just a glance to clinical indication. Clinical indication of artificial hair is diffuse thinning and totally depleted donor areas. That happens also in the menopausal women. They start to have a great degradation of the hair follicle density. Another very important area are the surgical correction of scalp scars and burns after neurosurgery procedure for tumors, for instance, or accidents, railroad accident, and plastic reconstruction. But the indication is specific not only for male, but also for female patients when they seek immediate and not hospitalized outpatient results. What is the reason of this success? The reason is that biofiber 4.0 is the last technological innovation of the company and is highly compatible with the skin. And also they prepared also multi-high density implantation fibers that can in the same hole implant 3 fibers and achieve a very rapid growth and growth effect of the replaced hair, and they are not to be used in the frontal hairlines because single fibers give less dermatological reaction. Finally, last but not least, also the automatic implanter device is a very revolutionary product that allows to place up to 800 fibers per hour, thus significantly reducing the scar trauma compared to the manual tools used since now. Next, please. We discuss the systemic and local contraindication. Obviously, all the infection, hepatitis, HIV, autoimmune pathologies, and immune deficiency are contraindication, generally speaking. But in the issue of dermatology, dermatitis must be fully normalized before any scalp procedure. And we have to exclude systematically all the seborrheic and atopic patient, especially in the acute phase. Also, the allergies to implant materials must be warned, but usually polyamide coated like Medicap produces is very, very well tolerated. And finally, there are also some behavioral and psychological contraindication because the patient can be not suitable for a proper follow-up, hygienic follow-up of the transplanted hair, or have some psychological tickets, drawbacks like trichotillomania, which is the tendency to strip off the hair just as a nervous tick. In these cases, the implant area is usually devastated by this kind of psychological patients. Next one, please. Now, how many fibers we can implant per each session? Usually, 600, 1,000 can be implanted in a single session. That is the tolerability of the patient to local anesthesia, and the total number can reach also 2,300, usually an average per patient. And the lifespan expected after implant is 7-8 years. And usually we do the following implants if we do step by step the whole implantation each month, reimplanting the follow up to do the 2,000-3,000 of units at the end of the procedure. The yearly shedding rate is usually very low, no more than 10-15%, usually, very rarely more than 20 or 30. Next one, please. Now we will discuss what are the depths, the errors, the mistakes that we are facing during the procedure. The first one is the depth. It is the depth of implantation. If this implantation is too superficial, then the fiber loss is very high because the fixation point is not deep enough. There is also a location error, especially when implant too deep in the temple area, in the frontal hairline. And if we go too deep in the dermis, we find a very, very diffuse capillary network which can bleed and can exudate inflammatory cytokines. So too superficial or too deep are the drawback that we have to avoid usually in this procedure. Also, the density error is critical because we cannot implant more than one fiber per each hole. If we do more than 1, 2, or 3 fibers, usually the skin reacts with the producing of sebum and inflammation. So excess fibers must be immediately removed. There is a final error which consists in the trauma during the automatic or manual insertion when we make small laceration of the skin of the epidermal area, or we move the needle tip too strongly, and we can provocate small hemorrhages. Next one, please. So the four steps for successful implantation is preoperative normalization of the skin of the scalp. We have to remove any inflammation or infection or excessive sebum scales. Secondly, we have to do a methodic continuous cleansing during and after the procedure, using povidone iodine or hydrogen peroxide and chlorhexidine during the procedure with repeated rubbing over the skin. And phase 3, we have to personalize the prescription according with the information that we have about the patient, intolerance, allergy, or products usually utilized by the patient during her care, and also strict maintenance in the follow-up to the meeting with the hair dryer, and poor hygiene and lifestyle non-compliant is the leading cause of the procedure failure. Next one, please. The results of the complication management is quite good, because only 9.7% experience mild to moderate inflammatory or infection complication, primarily driven by inadequate patient aftercare. But of this percentage, 97.9% have a complete resolution on average in 15 days, with some antibiotics locally or orally, and with local steroid therapy. And only 2.1% need removal if the fiber have provoked a long-standing inflammation, but that is very unusual. Next one, please. What is the psychological impact of artificial hair implants? Let's see, we have a very good result also in terms of Hamilton scale, multicentric 3-year study on 278 patients, with a subjective and objective improvement in self-image of the patient. But this psychological satisfaction, as stated by Torello Lotti, a very important dermatologist in Italy, we have an overall clinical success because the patient feels reassured in his social role by implanted hair replacement. Summarizing, beyond aesthetic restoration, the immediacy of the results drives a rapid recovery of self-esteem, social confidence in both male and female patients, and they want to repeat female, making a high input quality of life intervention. Next slide, please. Now, a short puntualization about the medico-legal aspects of artificial hair. First of all, the procedure is restricted exclusively to qualified medical doctors, because unauthorized practice is documented to give several time complication. So the patient has to sign, obviously, an informed consent, and the doctor has to be trained by the company in a very scrupulous way to achieve quickly the manual dexterity for using the implantation device or the manual implantation of artificial hair. And they have to demonstrate technical mastery either in manual or in automatic machine. And the product has to be absolutely certified by CE MDR, because this is a guarantee that the quality of the material is absolutely well tolerated. Next one, please. And finally, we can tell that certified materials, biofiber 4.0, CE/MDR regularly registered. Technical mastery, we have to do properly the procedure without any drawback in terms of manual security and manual dexterity, and also rigorous patient selection, which is the first criterion in order to avoid untoward effects. The scalp has to be absolutely in optimal condition and pre-treated if needed to be very, very receptive to the implant. Next one, please. This is a certain number of literature reports, obviously clinical study on the patient, and you can read in extension these papers contacting the website of the company, and they all confirm the optimal tolerability and also the specific indication of the artificial hair implants. Next one. I want finally to give you my contribution about a trick that can help the successful implantation of the artificial hair when I use the derma roller over the skin area to be implanted, because derma roller is a multi-needle, very, very tiny needle that is used especially in the Asian countries in order to revitalize the skin, and especially face skin in prevision of skin relaxation due to age. When we use the roller over the scalp, this is the first time that this technique is proposed, we can see many bleeding spots for a while. Stopping this bleeding stop, we can implant the artificial fibers in between the coagulated microvascular points. Doing this procedure, we avoid to transfix and to give trauma to the sebaceous gland usually surrounding very strictly the vascular network of the scalp, because pilosebaceous unit is supplied by a specific axial vascular vessel and is in strict contiguity with the vascular network. So if we implant the fiber in between the bleeding area, we are reasonably sure that we will not interact or transfix any sebaceous gland. Next one, please. This is the backbone of our studies on 7 patients, where we did dermarol assisted side versus the other side not treated with dermarol, in order to compare on the same patient in different side the protective effect against inflammatory and sebum response. And the next one, we implanted 50 fibers artificial on each side, and you can see that 1 month, 2 months, and 3 months after implantation, the seborrheic reaction is lower on the side that has been implanted previously derma roller application, compared with the other side where derma roller was not applied, and the injection of the fiber was done randomly without selecting the space, the vascular space in between the spotting the blooding spot. Next one, please. So the conclusion is that the derma roller assisted implantation can represent a simple and reproducible enhancement of artificial hair implantation success. Microneedling helps to avoid pilosebaceous vascular structures during implantation. Potential improvement in long-term implant stability and patient satisfaction is enhanced, and this technique might become a standard adjunctive protocol in biofiber implantation. But the take-home message of my lecture is that biofiber is really a good advancement in the hair restoration technique for men and women, especially where is a scattered loss of hair after menopause, and also after 50, 60 age, also in the man. And this can be a very, very outstanding and appreciable immediate replacement of the patient without long time before observing the result. Thank you very much.
Okay, next, please. Next slide. Okay, and again, next slide. Let's move on. Yeah, the background. It is about some clinical observation and treatment. First, I would like to thank, of course, the organizing committee of the meeting. I am so sad I couldn't make it to Kuala Lumpur. I was so happy to fly there, but yeah, some things are above our will. And of course, a war is not a simple matter. Uh, there's a war between Europe and Kuala Lumpur right now. So I hope it ends very soon. The background is about hyaluronic acid causing some unexpected and unwilling complications. Next slide, please. Next slide. Okay, thank you. And it is about the activity of the long chain hyaluronic acid. Long chain hyaluronic acid can cause fibrotic reaction. We know that from other mechanical irritation of the fibroblast from the past, but we go there in the next slides. Next slide, please. And again, it is a fact that the long chain hyaluronic acid can cause unwanted reactions. Next slide, please. I would like to move on. Yeah. The observation and the fact is that long chain hyaluronic acid can exert a fibrotic reaction when injected into a skin area of mechanical stress. This is what all is about and how to explain our observation exactly. Thank you. You will see next slide. It's good that we go to the to some pictures. Next slide, please. The clinical findings is that we could find a sausage. You can see in this picture, can you stay very shortly here? You see minimal difference between those two pictures. And there is 6 weeks between those two pictures. But next slide, please. Yeah. In this slide, you can see exactly all the clinical findings which I described. I mean, Professor Haneke and me. You can see the bulky cheeks. You can see the disappearing of the nasolabial fold. And you can't see, but it's I can't show it. The eyes are getting smaller, and yeah, as we said, and if you go with your finger and palpate the cheek, you will find in the before the treatment so a time, you will find just a sausage like rubber along the nasolabial fold, which is a fibrotic reaction. That means a collagen producing reaction, collagen fibers caused by the big molecular hyaluronic acid, long chain hyaluronic acid, which is right mechanically irritating the fibroblasts to produce collagen. Next slide, please. As I say, in the physical examination on smiling, distortion of lip shape, and presence of a bulge in the subcutaneous space along the nasolabial fold. And if you palpate it, you do it just from curiosity, please do it. If you see a lady with bulky cheeks, 90%, she has a sausage-shaped structure lateral to the nasolabial fold. And the consistency is not the one of hyaluronic acid. If you feel it, you don't feel hyaluronic acid reaction, you feel a total different and much more rubber-like consistency, just like a fibrotic fibrotic reaction or just like an internal scar, so to say. Next slide, please. Yeah, again, I repeat myself, but it's important to get this. The Risorius and the zygomaticus major muscle are pulling the oral commissure, and the lips are pulling up this bulk, which then secondary is causing distortion of the oral commissure. It's a mechanical phenomenon.
What you can see here is.
Can we go to the next slide, please? Okay, I would like to move on to go to the pictures because a picture is giving much more evidence. Yeah, okay, stop here, please. You can see that this is a very, very old picture from the analysis of the picture. I have started treating the ladies who have been treating with silicone. We know that silicone is a main collagen inducer, and the fibrotic reaction is caused by silicone. So I have been treating this 25 years ago with triamcinolone, and you can see the improvement, the reappearing of the nasolabial fold, which is totally disappeared, and that's what make me actually find this bulge in the patients treated with hyaluronic acid in the nasolabial fold, because it was exactly the same reaction like silicone. Next slide, please. So we have seen this before. Again, next slide, please. Yeah, next slide, please. Okay, here we can see it's no big difference in the before and after. But next slide, please. We can see that after the treatment, the bulky cheeks are getting less in volume. The nasolabial fold reappears. The Joker smile is reduced. And if we could see the eyes are getting a little bigger than before, but always upon smiling, because I will say that again, upon smiling, the bulge is pushing the cheeks outwards and causes this bulky cheeks. Next slide, please. Thank you. Again, in this lady, we could see, we can see a big difference. Maybe we can see that the nasolabial fold is a little bit altered. And if you hold in the left, in the previous one, in the before slide, in the before patient, palpate with your, I mean, just next slide, please. In the left slide, if you do like this, I mean, palpate and get the feeling of the skin. And when you come here, if you have a lady with overfilled, bulky cheeks, you will feel here 90% sure you will feel here a bulky sausage just here. And this is where the triamcinolone is injected into and is causing a partial atrophy of this fibrotic reaction, bringing back the face to its normal condition. Next slide, please. Yeah, we can see that. Previous slide, please. Okay, we can see the bulky cheeks before and the normal appearance of the face after. Next slide, please. Again, before there's no big difference, but after, next slide, please. Yeah, you can see that the bulky cheeks, you disappear and the nasolabial fold reappears. And also the Joker smile improves. And we don't have these bulky cheeks anymore. It's a clinical trial. It's not a study with microscopes or whatever, but it's a clinical treatment. It's a clinical observation, and you can see the results. Next slide, please. Okay, this is not very because of the kind of face, but you even see. Next slide, please. Next slide, please. Yes, you can see upon smiling, the cheeks are much less. Next slide, please. Yeah, okay. When they don't smile, you see a very, very minimal difference before and after the treatment. But next slide, please. Yeah, when they are smiling, this sausage is pushing the cheeks out and causes this bulky cheek phenomenon. And after the solving of this fibrotic sausage, you can see that the bulky cheeks are reduced, the face gets a normal appearance again, the oral commissure is getting a little bit better, not very much Joker-like. And of course, the eyes are getting a little bigger, but I am not allowed to show that. Next slide, please. Another case, no big difference left and right, but next slide, please. Yeah, you can see that after solving the fibrotic sausage, the face gets a much more normal appearance and the bulky cheeks are reduced. Next slide, please. It's another case, no big difference between the two before and after, but next slide, please. Yeah, you can see the bulky cheeks pushed by this fibrotic sausage. And fibrotic sausage is gone, the nasolabial fold reappears, the bulky cheeks disappear. I say that again, it's very easy. Do it in every patient of yours. Just try, go with the little finger who has a better pressure feeling and just feel your skin like this and you get the feeling of the normal skin. And when you're here in a lady with bulky cheeks, in front of the nasolabial fold, you will feel a sausage, a rubber-like sausage. And this is the fibrotic reaction. Next slide, please. Again, a similar case. Next slide, please. Yeah, you can see, everybody can see that the cheeks are very, very bulky. And after treating that, the face gets, upon smiling, the normal appearance back. Next slide, please. Yeah, no big difference before and after, but next slide, please. Yeah, you can see it. The bulky cheeks, they are there, and they are gone after solving the sausage. So just do it, please. I inject, just for the record, about 5 milligrams of triamcinolone in crystal crystal triamcinolone suspension in every sausage. I say that again, 5 milligrams of triamcinolone crystal suspension in every sausage. You have to palpate the sausage, you have to find it, to immobilize it, and then inject into the sausage. And you feel a little difference in the resistance when you go with your needle into the sausage. I mean, if you're an experienced injector, which I think all of you are, you will feel this. Next slide, please. Why so many nasolabial fold treatments all over the world? Maybe it could be because I was there at the time. In the very first filler who came to the market, the Zydarm and the Zyplast, the official FDA approval was correction of the nasolabial fold. So the nasolabial fold stayed a prime goal to correct, but the times are changing, the fillers are changing, the reactions are changing, and the world is moving on. Next slide, please. So can we make the overfilled phase reversible? Next slide, please. Yeah, the answer is yes. You can see that. Next slide, please. So discussion, again, the same. We have discussed this before. It's a very simple procedure, and we all know that mechanical stress and big molecules are inducing collagen production, and this is the case. Please, again, I say it again, please do this in front of the tragus. You have a lady with bulky cheeks, do that. And before you reach the nasolabial fold, you will feel into the skin a bulky sausage-like mass. This is the fibrotic reaction. Next slide, please. Yeah, again, this is always all we have discussed before. I don't want to waste your time. Triamcinolone crystal suspension is a very effective solution. Again, next slide, please. Next slide. Yeah, the facial overfill syndrome. Everybody talks about the facial overfill syndrome, but how much is this nasolabial fibrotic reaction contributing to the facial overfill syndrome? We always see around ladies when they smile and they get the bulky cheeks, the ping pong effect. Next slide, please. So we can see, even in this picture, disappearing on nasolabial fold, bulky cheeks, distortion of the oral commissure. The eyes are definitely smaller, are acting smaller. Next slide, please. Yeah, again, we need to consider this as a possible treatment of the facial overfilled syndrome, or maybe a contribution to the treatment of facial overfilled syndrome. Next slide, please. So, conclusion, we have discussed this before. The hyaluronic acids fillers are safe, but complications can arise. Next slide, please. Again, the same. Sorry to repeat it, but it's important that we really realize what is the matter. And the matter is just that big molecular hyaluronic acid can cause fibrotic reaction. Next slide, please. Thank you very much.
much. And I'm just a cosmetologist, not a doctor. Thank you for the opportunity to take part in this conference among such specialists as you. I would not be here today without my supervisor, Dr. Karolina Trzeciak, who guided and supported my work. I am deeply grateful to her. I am not a doctor, but by learning about the amazing connections between the system of the human body, the relationship inside the body, and what we finally see on the skin, I can look deeper into a problem and understand the real causes of what my clients struggle with. And this topic is also very personal to me because it is my own story. Since childhood, I struggled with skin problems, allergies, and migraines. I was sent from one doctor to another, and very often I heard that there was no real cause, that is just the way I am. But I couldn't accept that intelligent and complex human body could function with no reason behind these problems. So I started to search deeper and I become more and more interested and understanding the human body. And this journey eventually led me to the gut and the digestive system. And now I can share this. And I am cosmetologist and people come to me with different skin problems, hoping to improve them. Thanks to the knowledge of nutrition, psychology, physiology, and the connection between the skin, the digestive system, especially the gut, and emotions, I can guide my client to look more carefully at the condition of their own bodies. I can inspire them to repair what is most important, their health. And this is our common mission. Cosmetologists, doctors, dietitians, psychologists, and many other health specialists to guide our patient in the right direction and help them to restore their beauty, which truly comes from health, from what is happening in the gut and in the mind. Now I would like to show you two of my clients. And next slide, please. At first, both cases look like typical inflammatory acne, redness, breakouts, and ongoing skin problems. Both girls were really taking care of themselves. They followed good skincare routines, were consistent with their treatments. They paid attention to what they ate and tried to choose healthy food. They also did regular basic health tests. Their lifestyle was active. They went to the gym, swam, and practiced yoga. So from the outside, everything looked balanced and healthy. And yet, their skin was still struggling. This is the moment when we need to stop and think a little deeper. Because if everything seems to be right, but the skin is not improving, then maybe the problem is not only on the surface. So the question is, what was the real cause? And the next slide, please. In the first case, the main problem was candida overgrowth, a type of yeast in the digestive system. Step by step, by looking at all her symptoms, she decided to do proper testing, and it confirmed the imbalance. When we look deeper into her history, it became clear why. Since childhood, she had been treated with many courses of antibiotics due to frequent illnesses. This had a strong impact on her gut microbiome. In this second case, the situation was different. This client had been struggling for a long time with abdominal pain and food intolerances. After further diagnostics, she was diagnosed with SIBO, small intestinal bacterial overgrowth. So instead of focusing only on the skin, we started to look for the root cause of this condition. We considered factors such as parasites and Helicobacter pylori infection, and this changed the whole direction of the therapy. So what did we find? In this case, the problem was not only one single condition. It was a combination of factors, a very restrictive diet with limited food choices, a high level of stress, very intense physical activity, very little sleep, and constant pressure and high expectation. All of this together create a very strong oxidative stress in the body. And this led to an imbalance in both the digestive system and the hormonal system. Why does this happen? Please, next slide. The brain, the gut, and the skin form an inseparable and very important triangle of connection. It is a subtle but powerful communication system in which each element influences the others. When stress appears, the brain activates protective hormonal mechanisms. The level of cortisol and other stress mediator increases. While this reaction is natural, chronic stress disturbs the balance of the body. It affects gut function, the microbiota, and the integrity of the intestinal barrier. As a result, inflammatory processes may increase. The gut, often called the second brain, is responsible for much more than digestion. It is a key part of the immune system and produces substances that influence our mood, inflammation, and overall body function. When its balance is disturbed, inflammatory signals are often reflected in the skin. The skin is a mirror of what happens inside the body. It reacts to stress hormones, inflammatory mediators, deficiencies, and microbiota imbalance. That is why conditions such as acne, atopic dermatitis, psoriasis often have much deeper causes than just surface changes. This mechanism works in both directions. Stress affects the gut affects the skin, and skin problems affect psychological well-being, increasing emotional tension. It becomes a closed circle of interaction. That is why a holistic approach is so important, looking not only at the symptom, but at the whole body. Because true beauty is the result of internal balance. This relationship is not accidental, it is biological foundation. During embryonic development, the brain and the epidermis come from the same germ layer, the ectoderm. This shared origin creates a very close relationship between the skin and the nervous system. The skin is not only a protective barrier, it is an active neuroimmunological organ that responds to neurotransmitters, stress hormones, and emotions. The gut, although it develops from a different germ layer, remains in constant communication with the brain through the vagus nerve, the main pathway of two-way communication between the nervous system and the digestive tract. This regulatory axis influences inflammation and the function of the microbiota and the overall balance of the body. In this way, shared embryological origin and neurohormonal communication form the biological basis of the gut-skin-brain axis. It is not a metaphor, it is a real physiological mechanism that explains why what happens in the mind and in the gut, of course, is clearly reflected in the skin. And next slide, please. Now I would like to focus more deeply on the gut, because very often when we see a skin problem, we are actually seeing a sign of gut dysfunction. To understand this, we need to briefly look at its structure and function. The gut is not only responsible only for digestion, it is a complex and active immune and metabolic organ. Its wall is built from enterocytes, specialized cells responsible for nutrient absorption. Between them are tight junctions which control what can pass into the bloodstream. Inside the gut, we also find GALT, gut-associated lymphoid tissue, one of the most important parts of the immune system. A large part of immune activity in the body is connected to the intestines. When this structure works properly, it acts as a strong protective barrier. But when it becomes disturbed, the consequences may appear on the skin. One of the key mechanisms is increased intestinal permeability. When the connections between cells weaken, particles that should not normally enter the bloodstream may pass through. The immune system reacts, inflammation increases, and the skin often becomes the place where this inflammation appears. We may observe acne, rosacea, atopic dermatitis, psoriasis, chronic dryness, hypersensitivity, or recurrent inflammatory changes. And next slide, please. Another very important factor is the composition of the gut microbiota. A healthy microbiome supports immune balance, produces short-chain fatty acids, regulates inflammation, and influences neurotransmitter production. However, an imbalance in gut flora may lead to chronic low-grade inflammation, which is often reflected in the condition of the skin. At this point, I would like to highlight one more important aspect of microbiome. We often think about the gut as something responsible only for digestion, but in reality, it is a very dynamic and intelligent ecosystem. Our gut is home to trillions of microorganisms, bacteria, viruses, and fungi. Together, they form what we call the gut microbiota. And what is really interesting in that this system is not passive. It is constantly communicating with our body. It reacts to what we eat, how we live, and even how we feel. In fact, we are not just human organisms. We function more like partnership, a symbiotic system. These microorganisms play many important roles. They help us digest food, they produce certain vitamins, and they create substances that reduce inflammation and support the gut barrier. But maybe even more importantly, they work very closely with our immune system. And when this balance is disturbed, the immune system can become too active. This can lead to chronic inflammation, increased sensitivity, and even autoimmune reactions. The gut also communicates with the nervous system through different signals and substances. It can influence our mood, our stress, and how we respond emotionally. So when the gut is out of balance, we are not only more prone to inflammation, but also more sensitive to stress. And this makes the whole brain-gut-skin connection even stronger. So from this perspective, taking care of the gut is not only about digestion, it is about supporting balance in the whole body, because system influence almost everything, from immunity to emotions, and of course the condition of our skin. And next slide, please. At this point, we would like to focus more on inflammation because it is a one key mechanism connecting the gut and the skin. Inflammation itself is not something negative. It is a natural defense response of the body. The problem begins when it becomes chronic and stays at a low level for a long time. This type of inflammation often has no clear symptoms, but it is constantly active in the background, slowly disturbing the whole body's balance. And very often its source is the gut. When the intestinal barrier is weakened and the microbiota is imbalanced, pro-inflammatory particles such as LPS can enter the bloodstream. The immune system reacts and stays in a constant state of activation. And the skin is often one of the first places where we can see the effects. Next slide, please. And this is another very important piece of this puzzle, the vagus nerve. And I can see it's not slide with vagus nerve. And next slide, please. Oh, no. Okay, back. Can we back for the video? I told about vagus nerve. It is a main communication pathway between the gut and the brain. You can think about it like of regulatory cable that helps the body return to balance. The vagus nerve has the ability to calm inflammation. It works like a natural brake but chronic stress significantly weakens it. And when its activity decreases, the body becomes less effective at controlling inflammation. Gut function becomes efficient and the intestinal barrier becomes more permeable. In this state, even small trigger can lead to stronger reactions, which are often visible on the skin, not only at what we apply on the skin, but also how we breathe, how we sleep, and how we manage stress, because sometimes the biggest change for the skin begins in the nervous system. Can we back for a moment the slide before? Oh, thank you. And we should also consider problems such as damage or atrophy of the intestinal villi. The villi are responsible for proper nutrient absorption. When they are damaged due to chronic inflammation, food intolerances, infections, or parasitic disease, it can lead to malabsorption and nutrient deficiencies directly on the skin. Another important factor is eating habits. Many people during periods of stress choose highly processed food that are high in sugar and unhealthy fats. The typical Western diet is based mostly on processed food, and people often eat quickly instead of eating slowly and chewing properly. This kind of eating can cause quick changes in blood sugar and insulin levels, as well as digestive problems and too much harmful in bacteria in the gut. High level of insulin and the growth factor IGF-1 affect oil glands, skin cells growth, and increase inflammation. This is one of the reasons why a high sugar diet may make acne worse. It is also important to remember that problems with the gut and chronic inflammation may be caused not only by diet or gut imbalance, but also by certain digestive disease. These include Crohn's disease and ulcerative colitis. In these conditions, the immune system is always active, and inflammation affects not only the intestines but also other organs, including the skin. Skin is often where these problems become visible. And next slide, please. And one more time, next slide, please. Thank you. We clearly see that the gut is not only just a digestive organ, it is a regulatory center that influences metabolism, immunity, inflammation, and overall balance. Biological clock disturbance are also very important. Chronic lack of sleep, shift work, and consistent stress affect the gut microbiota and increase inflammatory processes. The skin reacts quickly to the loss of this biological harmony. The skin reacts very quickly to the loss of this biological balance. This creates a kind of vicious cycle. Stress affects eating habits, diet affects the gut, and the gut influences inflammation in the body. And that is why with work, with a client, skincare alone is not enough. The foundation is a good and detailed consultation, understanding lifestyle, diet, stress level, sleep quality, history of antibiotic use, and chronic disease. Then comes proper diagnostics and cooperation with other specialists, a doctor, a dietitian, and sometimes a psychologist. The diet should be adjusted to the specific problem of the patient, often anti-inflammatory and supportive of intestinal barrier repair. Supplementation should be also individualized. In supporting gut balance and reducing chronic inflammation, natural anti-inflammatory substances are also very important. Only on this foundation can we build targeted skincare, because skincare without internal balance often gives only temporary results. That is why lifestyle hygiene is also essential. Sleep, physical activity, stress management, and conscious nutrition. True skin therapy begins in the gut, and our role as a specialist is not only to improve the appearance of the skin, but to help the patient restore balance in the whole body. Thank you so much.
Good morning, ladies and gentlemen. My name is Agata Lebedowska, and this presentation was prepared together with Małgorzata Bożek. We are both from Medical University of Silesia in Katowice, Poland. Thank you so much for the opportunity to present here today. I would like to share with you the result of our pilot study investigating how skin parameters and body composition influence pain tolerance during electrical muscle stimulation in women. I hope you find it interesting. Electrical muscle stimulation, or EMS, is a method with a wide range of clinical and aesthetic applications. It is used for muscle strengthening, body contouring, fat reduction, and as a complement to physical training and rehabilitation. However, the effectiveness of EMS is closely tied to how well the patient tolerates the stimulation. And this is a key clinical challenge. If the procedure is too painful or causes significant discomfort, the patient simply stops, which means the therapeutic goals are never reached. It is worth emphasizing that pain perception is highly individual. It depends on psychological, physiological, and hormonal status. In women especially, these differences can be substantial. And yet, relatively little is known about how much body composition and skin parameters together influence pain thresholds during EMS, specifically in women. That was the starting point for our study. Our motivation was to identify factors that would allow clinicians to personalize EMS treatments, making them more comfortable and more effective for each individual patient. The primary aim of the study was to investigate how body composition and skin parameters affect a woman's tolerance to EMS stimulation. We formulated two specific research questions. First, which anthropometric and body composition factors are most strongly related to pain thresholds during EMS? Second, do skin thickness or dermal density play any significant role in this process? Answers to these questions have direct implications for clinical practice, both in aesthetic medicine and in rehabilitation settings. These questions are clinically relevant because discomfort during EMS often leads to early treatment termination. Identifying predictors of tolerance could allow clinicians to adjust intensity before the first session, improving both comfort and outcomes. And why women specifically? Women differ from men in body composition, hormonal profile, and skin characteristics, all of which may influence electrical current transmission and pain perception. Yet, gender-specific EMS data remains scarce. This pilot study included 16 healthy Caucasian women, aged 18 to 54, with a mean age of approximately 36 years. The exclusion criteria were quite extensive and intentionally so. We wanted to ensure that any variation in EMS tolerance we observed was genuinely related to body composition and skin parameters and not confounded by medication, skin conditions, or systemic diseases. Participants were excluded if they had received any light, laser, or radio frequency treatments in the area within the previous 3 months. We collected data using 3 main measurement approaches. First, standard anthropometry, body weight, height, waist and hip circumference, BMI, and skin fold thickness measured with a caliper directly beside the navel. Second, bioelectrical impedance analysis using the InBody S10 device, which gave us detailed body composition data. For this measurement, we followed a strict preparation protocol. Participants fasted for at least 4 hours before the test, emptied their bladders immediately before measurement, and rested in a supine position for 15 minutes prior to electrode attachment. This was important to minimize variability in hydration-related readings. And third, high-frequency ultrasound imaging of the abdominal skin using the DAP skin scanner with 22 and 50 MHz transducers to assess epidermal thickness, dermal thickness, and dermal density. Scans were taken 5 centimeters below the navel, in the lower abdominal region, which is also the area where the EMS applicators were placed. This allowed us to assess skin parameters directly at the site of stimulation, which we felt was methodologically important. The EMS stimulation was performed using the Evolvex device by InMode, a device designed for body contouring that combines non-invasive radiofrequency and EMS. 4 applicators were placed around the abdomen, 2 just above and 2 just below the navel, aligned with the rectus abdominis muscle on both sides. The intensity was gradually increased from a low starting point until the participant reported pain that prevent further continuation. That voltage was recorded as a maximum tolerated intensity expressed in volts. For statistical analysis, we used a Spearman's rank correlation. This was appropriate given our small sample size of 16 participants and the fact that not all parameters showed a normal distribution in the Shapiro-Wilk test. Results were considered statistically significant at p less than 0.05. So what did we find? The maximum tolerated EMS intensity varied considerably across participants, from as low as 12 volts to as high as 55 volts, with a median of 33 volts. This wide range is itself tell us something important. Women differ substantially in how much EMS stimulation they can tolerate. When we looked at which factors explain this variation, a clear pattern emerged. Parameters related to adipose tissue, fat mass, percent body fat, visceral fat area, BMI, skin fold thickness, hip circumference, and body weight were all significantly correlated with EMS tolerance. On the other hand, parameters related to muscle tissue and body water showed no significant correlations. And notably, skin structural parameters measured by ultrasound also showed no significant effect. As you can see in these scatter plots, all 5 correlations shown here are statistically significant. And all of them are positive, meaning that higher values consistently correspond to higher EMS tolerance. The strongest predictor was body weight, panel A, with a Spearman's R of 0.76 and P less than 0.001. This is a strong and clinically meaningful correlation. Hip circumference, panel D, followed closely with R of 0.66 and P equals 0.006. Skin fold thickness, panel E, and BMI, panel C, both also reached significance with R of 0.61 and 0.56 respectively. The pattern is very clear and very consistent. The more adipose tissue a woman carries in any of these measures, the higher her tolerance for EMS stimulation. Moving now to body composition parameters measured by bioimpedance, the picture is equally consistent. Fat mass in kilograms, panel A, showed an R of 0.61 with P equals 0.012. Person body fat, panel C, reached R of 0.52, P equals 0.041. Visceral fat area, panel D, showed R of 0.55, P equals 0.029. This is particularly interesting here is the visceral fat result. Even fat stored internally around the organs correlates significantly with EMS tolerance, not just fat layer beneath the skin. This further supports the insulation hypothesis. Together, these two slides tell a very coherent story. Across both external measurements and internal body composition analysis, adipose tissue is a dominant factor determining how much EMS stimulation a woman can tolerate. Now look at what did not significantly correlate with EMS tolerance. In terms of muscle tissue, fat-free mass, soft lean mass, and skeletal muscle mass all showed no statistically significant relationship with tolerance. Body water compartments, total body water, intracellular water, and extracellular water were also non-significant. It is worth noting that all hydration values in our sample were within normal ranges, which likely explains the absence of water-related effects. Had we included participants with abnormal hydration, the picture might have been different. And finally, skin structural parameters. Epidermal thickness, and dermal density all failed to reach statistical significance. Dermal density showed the strongest trend among skin parameters, but it remained below our significance threshold. And how do we explain these findings? First, adipose tissue acts as an electrical insulator. Fat is significantly less conductive than muscle or blood. A thicker layer of fat beneath the skin attenuates the electrical current before it reaches the muscle, which means that at the same voltage, a woman with higher adiposity experiences less direct muscle stimulation and therefore less discomfort. Second, and this is the flip side of the same mechanism, lean women feel stronger contractions. When there is less fat between the electrode and the muscle, the electrical field covers proportionally more muscle tissue. This leads to stronger and more widespread contractions, which the participant experiences as more intense and more painful. Third, the normal hydration range in our sample likely masked any water-related effects. All participants had hydration balance values within normal limits. Water is an excellent conductor of electricity, so if we had included participants with edema or significantly abnormal hydration, we might have seen different results. Interestingly, other published studies have shown that higher body water content is associated with lower thresholds for electrical current perception, which is consistent with our hypothesis, even if our data did not reach significance. And fourth, skin structure appears to matter less than deeper body composition. Despite our initial hypothesis that dermal thickness and density might play a role, given their known influence in radiofrequency treatments, they did not reach significance here. This suggests that when it comes to EMS tolerance, what happens beneath the skin matters far more than the skin's surface properties. Let me summarize the key takeaways. 1. Pain tolerance during EMS varies widely among women, ranging from 12 to 55 volts in our sample. This variability is clinically relevant and cannot be ignored. 2. Body composition, and particularly adipose tissue, strongly influences this tolerance. Higher body weight, hip circumference, skin fold thickness, and body fat percentage all predict greater tolerance. The mechanism is likely the insulating effect of fat on electrical current transmission. 3. Muscle mass, body water, and skin structural parameters show little to no effect on EMS tolerance, at least in a healthy and normally hydrated female samples. 4. Taken together, these results underline the importance of evaluating body composition before initiating EMS therapy. Doing so would allow clinicians to better predict a patient's tolerance, adjust intensity accordingly, reduce discomfort, and ultimately improve treatment adherence. And 5, given the pilot nature of this study with only 16 participants, larger and more diverse studies are needed to confirm and extend these findings, including male subject and women with more varied body compositions. To conclude, I believe this study, while preliminary, offers a meaningful and clinically actionable message. Evaluate body composition before EMS, predict tolerance, reduce discomfort, and improve adherence. So thank you very much for your attention, and I'm happy to take any questions.
So I'll be covering my topic, diagnosis and management of plaque-induced gingival soft tissue complications around natural dentition. Next slide. Next slide, please. Yeah, this is my workplace, my institute, and other platforms where I've done my cases. Next slide. I'll be covering this topic under the basic concepts: what is gingival thickness, width of attached gingiva, their importance, and how we can improve them by microneedling, injectable PRF and vitamin C, non-surgical methods. Next slide, please. I'll also portray some case reports about gingival phenotype improvement, vestibular extension procedures, treatment of periodontal pockets, aberrant frenum and frenectomy techniques, gingival enlargements, what is gingival hyperpigmentation and depigmentation procedures, inflammatory pericoronal flaps, and contribution of systemic factors. Next slide. So how do we assess gingival thickness? It is done by transgingival probing or bone sounding. It is done under LA. It shows the cross-section of gingiva. It can also be measured with a periodontal probe, or an endodontic spreader is inserted perpendicular to the gingival surface until it touches the bone. And this is how gingival thickness is measured. Next slide, ma'am. Next slide. So less than 1 mm gingival thickness is thin phenotype, and more than it is thick phenotype. And thin phenotype has a higher risk of recession, less predictable healing after surgery, or any slightest trauma can also cause inflammatory response in thin phenotype, whereas thick phenotype is a more stable tissue and has better surgical outcomes. Next slide, please. What is width of attached gingiva? It is again an important parameter. It is the distance between the mucogingival junction and the projection on the external surface of the bottom of the gingival sulcus or the periodontal pocket, or in other words, it is just the gingiva which is firmly bound to the alveolar bone. Next. So importance of width of attached gingiva is it resists plaque from invading into deeper tissues of the periodontium. Hence, it stops its spread to the distant organs, and it resists the masticatory forces while chewing, also resists frictional forces from surrounding musculature. Next, ma'am. Next. So how is width of attached gingiva checked? It is done by previous slide, ma'am. It is done by tension test. This is done by stretching the lips or the cheeks to demarcate the mucogingival junction as shown in the picture. And we see whether there is movement of marginal gingiva with this maneuver. And if the free gingival margin moves, then it is considered as inadequate. The width of attached gingiva is inadequate. Next slide, please. So coming to the basic concept, what is gingival phenotype and biotype? Biotype is something which is determined and it is same for all specific organisms. And phenotype is the appearance of an organism or any tissue. For example, here the gingival tissue, and multiple factors are involved here like environmental and clinical interventions. So gingival phenotype is a three-dimensional gingival volume, which is inclusive of gingival thickness and width of attached gingiva or keratinized tissue width. Next. Next, ma'am. So each person has a distinct gingival phenotype depending on the size, location, texture, and shape of the gingiva. Individuals with thin gingival phenotype cannot maintain their oral hygiene and frequently exhibit gingival recession as slightest trauma produces inflammation in their gingiva. Next. Ma'am, next slide. So our intention or objective of a study was to increase the gingival thickness and width of attached gingiva with simple non-surgical methods like microneedling, injectable PRF, and injection of vitamin C into the gingiva. So first procedure is microneedling. It is very commonly used in dermatology, and it is collagen induction therapy. It is used in gingiva also. Very recently, a 30 gauge lancet needle is inserted into the gingiva in horizontal direction until it contacts bone, and it is done on keratinized gingiva as well as the alveolar mucosa. By this maneuver, numerous pinpoint bleeding microchannels are created in the region to be treated. For example, we have done this in lower anterior sextant of gingiva. Next, ma'am. Next slide. So it leads to micro injuries, causes superficial bleeding, and creates a wound healing cascade, releases growth factors like transforming platelet-derived fibroblast and connective tissue growth factors, which increase the proliferation of new cells, which are immediately released after injury. And these cells, that is fibroblasts, which are newly formed, they promote new angiogenesis, that is formation of new blood vessels, and new collagenesis, that is formation of new collagen fibers. All this help in thickening of the gingiva. Next slide, ma'am. Next. Another clinical intervention is the use of injectable PRF or platelet-rich fibrin. We prepare this by withdrawing a 10 ml sample of venous blood from antecubital fossa and centrifuging this at room temperature with a tabletop centrifuge machine for 2 minutes at 2000 RPM. Next. The straw-colored fluid which is formed is injected into the gingival surface. And IPRF is also rich in growth factors, platelets, and leukocytes, which promotes regeneration process at low speed centrifugation process. Next. Next. Vitamin C is a very inexpensive drug, which is also used for thickening of gingiva. And it has very good characteristic features like it is an antioxidant, That is, it helps in post-operating healing of the tissues, contributory effect on reducing the gingival hyperpigmentation also, and it helps in collagen synthesis also, helps in differentiation and maturation of fibroblasts. So it thickens the gingiva also, helps it to turn into a thick phenotype so that it can resist inflammatory forces better, and also can help in depigmentation of gingiva. Next. Methods of measurement of gingival thickness, as I told you, it's a small endodontic spreader. Next, ma'am. Next. So an endodontic spreader along with a silicone disc is inserted at the gingival zenith on the gingival surface, and the depth of the penetration is measured with a vernier caliper to see the thickness of gingiva. Next, ma'am. So this is a study which we did. In this, for 4 appointments every week, we injected vitamin C into the gingival surface. So for 4 appointments, we did microneedling with a small lancet needle. Next, ma'am. Next. And 5th and 6th appointment, we injected vitamin C into the gingival surface at epithelial connective tissue junction. Next, ma'am. Fifth and 6th appointment, vitamin C mesotherapy. Next, ma'am. Next. So after 6 months of this treatment with microneedling and vitamin C, we got very good results in thickness of the gingiva as well as the width of attached gingiva. So vitamin C is really a predictable, very inexpensive method, non-surgical method for increasing the thickness and width of attached gingiva. Next, ma'am. Next. Yeah, this is a case where we did microneedling for first 4 appointments. And next, ma'am. Next slide. And 5th and 6th appointment, we injected IPRF with an insulin syringe into the gingival surface. And the results were comparatively less better than vitamin C, although it was better as compared to the pre-operative measurements. Next, ma'am. Next slide. Coming to another soft tissue factor, which can be deteriorating because of plaque. So Plasek and co-workers classified frenal attachments into 4 types: mucosal, gingival, papillary, and papilla penetrating type. Frenum is actually a band of mucous membrane with or without embedded muscle fibers, which is present most commonly in between the 2 central incisors, upper and lower. If it is a broad frenum, it can cause diastema and can cause aesthetic problems, and also can pull the gingiva in apical direction and help to accumulate plaque and lead to periodontitis. So in the presence of adequate width of attached gingiva, papillary and papilla penetrating type of freni can be considered abnormal because they not only make it difficult for an individual to keep the toothbrush in that area, resulting in plaque accumulation, but also cause gingiva to move away from the tooth surface, making the area a plaque retentive site. Next, ma'am. Next. So this is the frenum, and it is a test which is checking for aberrant frenum. And this frenum is creating a diastema and also not allowing the patient to keep the toothbrush in that area, leading to periodontitis problems. Next. Next. Another test, apart from tension test to check for aberrant freni, is a Blanche test, where we keep the tine of the probe on the surface of the frenum and just push it in apical direction, and it will cause blanching of the incisive papilla. So if the tension test and blanch test are positive, we have to go for frenectomy. That means the frenum is aberrant and we have to surgically remove the frenum. Next. So we have done frenectomies with lots of methods. First is the classical technique. We just stretch the lip. The assistant stretches the lip and holds the frenum with a hemostat or an artery forceps, and a 15 number blade is just moved above and below the hemostat. Next, ma'am. Next. Yeah. So after removal of the frenum, undermining of the epithelial edges is done with a 15 number blade or Castroviejo scissors, and then both the incisions are brought together and sutured, and we have got very good results with the classic technique also. Next. Next. Another technique is a paralleling technique of frenal removal. After stretching of the lips, just with 2 vertical incisions, frenum is incised, and those 2 vertical incisions are met with horizontal incisions. The incision lines are brought together and sutured, and this also gives very good results without any scar. Next. Another method for very broad frenum is just give 1 incision in a vertical direction in the center of the frenum and 2 slanting incisions in V-shaped on upper left and lower right corners of the straight incision, and then undermine those epithelial edges, bring them together and suture. This is a very good technique for broad frenum, and it also removes all scars. There are no scars in the post-operative healing period. Next. Another method is a VY-plasty. It is done for medium consistency aberrant freni attachments, and just the frenum is relieved on either side with a V-shaped incision with 15 number blade, and suturing is done in a Y shape. That is why it is known as VY-plasty. It gives good results in medium consistency frenal attachments. Next. So Miller's technique is one very good method of frenal removal in those patients who are just completing fixed orthodontic treatment and are going for retainers. But during use of retainers, relapse should not occur. So the frenum is removed with a paralleling technique, and a lateral paralleling incision is given on any one side of the incision of the frenal of frenectomy, and that lateral pedicle flap is brought in the middle of the incisions, and they are sutured together. It gives very good results and does not cause any relapse of the diastema in the post-orthodontic treatment period. Next. So another very good removal of frenum we require in lingual tie cases or tongue tie cases. Here the patient cannot protrude the tongue till the vermilion border of the lip, and the frenal attachment is just less than 3 mm under the tongue, and the patient when touches the palate can open the mouth. When patient touches the palate with the tongue, can open the mouth only for 2 or 3 mm only. So then we remove this frenum or relieve this frenum by giving LA in the floor of the mouth and just passing a 3 number reverse cutting suture from the tip of the tongue. Next. And just we have to move the soft tissue diode laser tip, which is a diode laser. We do not require any cutting instrument along with it. It works on pulsed mode. And just with the suture thread, we move the tongue up and just move the soft tissue diode laser tip touching the tongue. And we got very good results. Next slide, ma'am. Yes. So the patient was able to move the tongue till the vermilion border of the lip and also can touch the palate with very good mouth opening. So laser or electrocautery is such an instrument. These are electronic instruments. If worked judiciously, they can be very good instruments for cutting also. At the same time, they cause coagulation also, and there are no bleeding problems. Actually, frenum is a very vascular tissue, and frenectomy involves a lot of bleeding. So if we use electronic gadgets judiciously, we can do miraculous surgeries with these instruments. Next. Next, we did with electrocautery. It is a monopolar instrument, and for this, it is same as laser. It works same as soft tissue diode laser. Only thing, we have to give the patient a passive electrode in the left hand or touching any part of the body, and we can work on the power of 5 or 6 at cut and co-op mode. So we have done these maxillary frenectomies with electrocautery also with very good results. Next. Next. Same way, mandibular frenectomy also. Next. Yes. Then another cases of frenectomy with laser. Next. Yeah, so here also frenotomy with laser. So best part is bleeding gets controlled very easily, and there is no need of suturing also, and we get very good results. Next. Okay, so next very important parameter for maintenance of plaque is the vestibule. Vestibule is the space between the lips and the alveolar mucosa, and this furrow is very important for maintenance of oral hygiene. Normal depth of the vestibule helps in proper maintenance of oral hygiene and also movement of food during mastication. In the absence of this, food accumulates on marginal gingiva and gingival sulcular area, resulting in progression of periodontal disease. Enough space for placement of head of the toothbrush and use of other oral hygiene aids means adequate depth of the vestibule. Next. Next. So if the vestibular depth is less, if there is no enough space for placing the head of the adult toothbrush in the vestibule, we can do surgical methods like just check the depth of the vestibule. If it is inadequate, then we make an arc-shaped incision in the existing vestibule with a 15-number blade and stretch the lip out and take a piece of epithelial graft from the palate. Next. And place this piece in the vestibule in the area which is denuded of epithelium and suture it properly, and we got very good results, and you all can appreciate that there is increase in the depth of the vestibule after 6 months. Next. So one more miraculous procedure for increasing the depth of the vestibule for maintenance of oral hygiene is just stretch the lip, lower lip, and give an incision in the vestibule with a 15-number blade and just cut a strip of periosteum till where we want the expected depth of the vestibule and just make a furrow in the bone. It makes a scar in this area, and the depth of the vestibule or the base of the vestibule is changed. You all can appreciate here the 6 months results. Next. Another case of free gingival grafting technique to increase the depth of the vestibule after harvesting the graft from the palate. So very good results have been obtained with the use of free gingival graft. Next. Coming to pocket therapy. So pocket is another irritating or plaque accumulating region, which actually occurs after plaque accumulation, and if it cannot be maintained, it can lead to further progression of periodontitis. So we have to remove gingival pockets with gingivectomy or removal of the extra gingival tissue with an external bevel incision. And newer techniques are gingivectomy with low-level laser therapy to increase the to decrease the healing time, then pocket sterilization with lasers and PRF insertion in pockets. All these techniques are newer techniques which we have tried with newer methods. I'll just complete in subsequent slides. Next. Gingivectomy followed by low-level laser therapy. So here we have gingival pockets where there is no bone loss. We have removed the gingival tissue, inflamed gingival tissue with a 15-number blade, and just moved a low-level laser therapy we have done on those wounds to decrease the healing period. So low-level laser therapy is nothing. The same soft tissue diode laser is used, but it is not used with the cutting mode. Here the tip is changed, and just for 10 seconds we keep the tip on the pulsed mode for low-level laser therapy, or we can also keep it on gingivectomy mode. Next. So pocket sterilization is another miraculous treatment which reduces the pocket depths and the bleeding from the pockets, and it also converts the edematous pockets into fibrous ones, which can be easily taken up for surgical procedure. So if there are very deep pockets and they are edematous, they are bleeding a lot, we cannot take them for surgical procedure. We need to do scaling and root cleaning and wait for some 15 days. And in those 15 days, we can just move the laser tip on pulsed mode on a pocket sterilization mode. Just move inside the pocket inner surface just for 10 seconds each tooth from mesial to distal ends, and it really produces fibrous pockets which we can operate for flat surgeries easily. Next. Another very good treatment for reducing pockets of 5 to 6 mm or making them ready for surgical procedure. Here pocket depths are measured. Then we have withdrawn blood, 10 ml of venous blood, and centrifuged that blood. Yes. So PRF can be put in periodontal pockets and we get very good results. Next. So this is how we do. Next. Next. Gingival enlargements can be either generalized or they can be focal, and their treatment methods are separate. Next. Next, ma'am. Yes. So gingival enlargement can be either treated with undisplaced flap, or we can use a legend wedge procedure like shown in B. Next. Next. Yes. So we have used legend wedge procedure. We have just given right angled scalloped incisions to remove the edematous tissue first, and then given clavicular incisions, and then internal bevel and interdental incisions. Next. So in such big enlargements also, we got fibrous tissue and good results. Next. Fibromas, these are focal reactive overgrowths. These are plaque-induced periodontal ligament cells. They get triggered and result in small enlargement. So this we have removed with gingivectomy. Here histopath shows lot of fibers in the tissue. Next. Next. Another case, peripheral cementifying fibroma done with gingivectomy. Histopath is showing lot of fibers and cementicles. Next. Pyogenic granuloma, big lesion, and done with gingivectomy as well as flap surgery both. And the histopath is showing lot of numerous newly formed capillaries along with lot of fibers. Next. Peripheral giant cell granuloma. This is also removed with flap surgery. And here the radiograph shows peculiar peripheral cuffing. And after removal of the tissue, we have seen in the histopath, there are numerous giant cells along with fibers. Next. Next. This is also a carious cavity which was not filled. Here again a gingival polyp has grown. This we have removed with a small 11 number blade, and the histopath is showing lot of fibers. Next. So all these are plaque-induced focal reactive growths. Here an 11-year-old patient has got a growth, and we have removed with gingivectomy. Histopath is showing numerous capillaries. Diagnosis was capillary hemangioma. Next. Yes. So another soft tissue surgery is depigmentation done with scalpel, 15 number blade used for peeling the gingival tissue. Next. Next. Done with electrocautery also. Next. Same with vitamin C also. Next. Inflammatory pericoronal flaps can also be removed if they are in class 1. Next. Next. They can be removed with scalpel. Next. Class 1 or class 2 can be removed with scalpel, electrocautery or lasers. Next, ma'am. Next. Next, ma'am. Next. Next. So systemic contributory factors also lead to severe soft tissue deformities around natural dentition. Next. An example is desquamative gingivitis. Here the patient complained of burning mouth syndrome, and the gingiva got peeled off when we just used a finger pressure. Here we just did tooth cleaning. All the teeth were cleaned, and a tissue was taken for biopsy, and it was lichen planus. The patient was stressed out. So histopath shows peculiar sawtooth shaped retipix, and we referred the patient, just did teeth cleaning and referred the patient to a physician for prescription of steroids. Next. So here patient is epileptic and was taking phenytoin, resulted in gingival enlargements. Next. So we substituted the drug along with consultation of the physician, and we removed the enlargement with gingivectomy as well as flap surgery, resulting in very good oral hygiene maintenance areas, and the histopath showed lot of fibers. Next. So conclusion is, plaque is the primary etiologic factor in gingival, periodontal and mucogingival problems, sometimes also aggravating the response of systemic contributing factors. Proper knowledge and diagnosis and use of good clinical acumen helps faster healing of diseased tissues, bringing superior health of the periodontium. Electronic gadgets should be employed judiciously to achieve maximum benefits in bleeding control and healing. Next. Next. Thank you.
So good evening, distinguished colleagues, dear friends. My name is Paweł Szychta from Gdańsk, Poland. Please feel warmly invited over here. It's a great place to be, and Malaysia is a perfect place to present our talk and to spend time at the cozy beach. But it's a truly privilege to join today as a keynote speaker. Today, I would like to present a concept that has progressively evolved through more than 10 years of my clinical experience and over 2,000 breast augmentation procedures performed with modern nano-textured ergonomic implants. So, breast augmentation is the most common aesthetic procedure worldwide, yet in the US market until recently, dependent mostly on smooth or macro-textured implant. Motiva ergonomic nano-textured implant entered the US only in 2024. My experience includes few thousand cases. Today, I will show how the Harmony protocol shifts focus from the implant size to proportion. So traditionally, the conversation was about size and volume. The Harmony protocol instead aligns breast contour with body proportions. We respect waist, hip, and shoulder hip ratio and tailor implant projection, mini, demi, full, or corset. The aim is balance and natural feminine proportions, not exaggerated augmentation. So in my cohort, over 90% reported high satisfaction on breast co. Objectively, chest width increased, breast base width also increased, and nipple IMF distance decreased slightly. Upper pole fullness improved, weight hip ratio was preserved, and overall silhouette was enhanced. The result? Harmony without disproportion. A clinical pearl. The patient motivations correlate directly with anthropometry and implant choice. And that's it about scientific results. Let's go to clinical science. This is a true paradigm shift. So from size to harmony, augmentation as proportion balancing, from texture problems to nanotexture stability. So low inflammation, high biocompatibility, no LCL. So from subjective feel to measurement softness, elastography confirms natural dynamics. The Harmony protocol combines anthropometry and motivation to guide implant projection. This ensures individualized, proportionate choices that balance body ratios with patient desires. And the clinical pair is this method bridges scientific measurement with artistic vision. Let's go into anatomy lab. When it comes to plane dissection, anatomical considerations should be focused on the enhanced tissue stability. Dual plane is the preferable dissection pocket due to the increased size support to the implant. So the pectoralis major can be divided into 4 zones, depending on its influence on the breast implant. Zones 1, 2, and 3 are the support zones, where zone 4 gives pressure to the implant in the lateral and downward direction. Zone 1 is largely disrupted during the access from the IMF. In turn, zones 2 and 3 should be left intact as the serratus pectoralis fascia. The additional tissue support in form of the split muscle sling created from the lower third of pectoralis major muscle and serratus anterior provides highest level of stability to the lateral and inferior portions of the implant as needed. So the surgery usually begins with the skin incision from the inframammary approach. The scarpa fascia is incised with cautery. The fascia of the gland is dissected from the muscle in the inferior breast pole up to the level dependent on dual plane. The costal margin of the muscle is incised to the level of the sternum, leaving at least 1 centimeter portion of the muscle intact acting as a muscle sling. And the submuscular pocket is prepared. After dissection, the muscle sling and the dual plane pocket are seen. The inframammary fold is recreated with 3 stitches, securing the both edges of the scarpa fascia to the deep fascia. The first one is placed in the middle of the wound, whereas two latter ones are placed about 1 centimeter medially and laterally to the first one. So the stitches are not that much required, as only 10% of the IMF is distorted. However, we prefer long-term stability in maximal extension. So the technique ensures consistent positioning, soft tissue preservation, and stable, long-lasting long-term results. When comparing textured and Motiva implants, differences are striking. Here, an explanted implant capsule in the lower part of the slide at 6 months shows how Motiva's nanotexture creates a translucent thin capsule. This reflects high biocompatibility, stability, and fewer complications. Shape is static, but feel and movement are dynamic. The missing preoperative dimension has been tissue elasticity. Elastography now converts softness into measurable numbers. This creates test thresholds to choose implant type, pocket plane, and support. So dynamic breast augmentation focuses not only on shape, but also on softness, movement, and natural biomechanics. Ergonomics to implants introduced substantial advancements in viscoelasticity and dynamic adaptability. I have been honored to be the author of the first publication in the world regarding ergonomics to implants. Ergonomics 1 implants have already offered spectacular outcomes of the natural-looking breasts, which are soft in touch and dynamic in everyday activities. However, innovation is a continuous strive for progress and enhancement. Here, ergonomics to implants come with improved surface and gel matrix for reduced risk of capsular contracture and even more natural feel and dynamic adaptability. Superior biomechanical congruity allows to achieve more naturalistic contour, and increased softness and pliability allows to mimic natural breast tissue more closely. Reduced rippling corresponds to a smoother surface. The study was one of the first reports evaluating not only breast contour, but putting stress on mimicking naturalistic breast properties in touch and dynamics. Breast pliability was evaluated using straight ratios on elastography in comparison between breast tissue, pectoralis major muscle, and implants along all breast quadrants, where ergonomics to implants resulted in higher breast softness. The study was also the first report in literature where elastographic analysis was also performed among different breast implants to showcase pliability of competitor microtextured anatomical, Motiva Round, Motiva Ergonomics 1, and Motiva Ergonomics 2 implants. In overall, Motiva Ergonomics 2 revealed significant improvement in the natural assessed as softness compared to all other breast implants. In summary, ergonomics to implants represent a significant step forward in the field of aesthetic breast surgery. They offer enhanced opportunities to achieve natural feeling and dynamically behaving breast augmentations, aligning well with current patient preferences and surgical trends. Modern breast augmentation should move beyond volume along towards harmonization of the entire silhouette. True success is measured in harmony, confidence, naturality, long-term stability, and patient quality of life. In conclusion, harmony, not volume, is the new frontier in breast augmentation. And thank you so much for your attention, and I welcome your questions.
Thank you, Dr. Pavel. That was a wonderful presentation.
Thank you so much.